Thank you. So it's not the first case in Pakistan, it's first case in the world. I would now like to request Professor Nadeem Hayat Malik to join our chairpersons. Now I would like to ask Professor Rosli Mohammed. Assalamu alaikum. Welcome to Pakistan Live. He will discuss about the role of drug-eluting balloon in coronary revascularization. It's Dr. Rosli. We can't hear you, Rosli.
I am unmute. Can you hear me now?
Now we can hear you.
All right, sorry. Can you see my slides?
Yeah.
All right. So once again, I must apologize for
we can't see your slides.
We can see it here.
Just hold on, sir.
Can you? Okay, I hope you can.
Okay, now we can see your slides.
All right, so thank you very much. I hope to be there next year, inshallah. Okay. All right, so if you look at the drug-coated balloon, especially with paclitaxel, the established indications are mainly with in-stent restenosis and small vessel disease. This is where the data is most established as compared to, compared to treating with either balloon angioplasty or with drug-eluting stent. There are some other lesions which are interesting. And when you look at the, know that for the fact that it gives out a more homogeneous drug elution into the tissue, the fact that there is no stent reduces the risk of lesion thrombosis, and it allows us for shorter DAPT duration, and the possibility that the vessel will function normally because the vessel is not caged by a stent. But there are more to it than that, because drug-eluting balloon or drug-coated balloon treatment has been shown that it leads on to late lumen enlargement following balloon angioplasty. And the first such work was by Franz Kleber, looking at a measurement of the lumen about 4 to 6 months after the first initial treatment, and about 70% of patients at least has an enlargement in the lumen. Not just that, if you were to treat bifurcation lesions, DCB can avoid coronal shift that can well happen with stent implantation. So this is something that is useful and beneficial, especially if you want to preserve the side branch. At the same time, because the fact that when you dilate the balloon, the drug can actually be eluted into the ostium, the side branch, and the ostial side branch can actually enlarge over time. And this has been proven in certain case description. But not just that. In a meta-analysis, it's been shown that drug-coated balloon has been shown to reduce the risk of myocardial infarction at 1 year, but also reduction in cardiac death and all-cause death at 3 years when compared to other modalities of treatment, in this case, looking at balloon angioplasty, bare metal stent, and drug-eluting stents. So those are all pleasing signs. But the issue is this: we need to expand the usage of drug-coated balloon, and nothing is like expanding it to a more wider range of treatment unless you are able to treat it and show that it's useful in de novo lesions in large coronary artery disease. Stent data is strong here. It's less time consuming, more immediately pleasing in terms of long-term in terms of immediate results. But really, if you feel that and you believe that you can try to leave nothing behind, this is something that you may want to consider. Okay. I hope that the reverse study that will hopefully be conducted the second half this year in centers of Malaysia, Singapore, South Korea, and Taiwan will address this issue. We're looking at 1,400 plus patients, randomizing this into DCB versus DS in a 1-to-1 fashion for a vessel size of 3.0 to 4.0. It's looking at non-inferiority results The primary endpoint at 12 months is net adverse clinical outcome. There are a host of secondary endpoints, and we'll be following up these patients for about 3 years. And there's a subgroup analysis undergoing angiographic follow-up at 9 months. So hopefully by 2025, we'll get some amount of data, at least to address this issue. But you and I, at this point in time, what do we consider when we want to use DCB? Obviously, the lesion indications, optimal vessel preparation, and after vessel preparation, then you decide, am I going to use DCB or am I going to put a stent in? So these are some of the less than ideal lesions. Left main stem, because you don't want to be mucking around with the left mains and there's no data with DCB. You want to be safe in this sense, you put it in the stem. Severely calcified lesions where there are concerns with drug absorption. But having said that, if you prepare the vessel well, you can have adequate calcium fracture. You may even be able to use a DCB in this case. And obviously, difficult to deliver DCBs, like very tortuous vessel with poor guide support. So when you look at all these lesions, you find that a lot of, or majority of lesions, there is a potential that you can actually use DCB. But and this is the emphasis on using DCB. The International DCB Consensus Group, the most recent in 2020, said that with optimal lesion preparation, you need to use a balloon, which is balloon to vessel ratio of 1:1. You have to prepare it very well. A specialty balloons like scoring, cutting, or non-compliant balloon is probably preferable, and with an option to use other devices like the rotablator, for example. And once you have acceptable angiographic result, and these are mainly based on a non-flow limiting dissection, residual stenosis of less than 30%, then you may want to consider using DCB. Otherwise, if for suboptimal angiographic results, you should stent this. But the fear is, the admonishment is this: you must not be using DCB as for POBA. It is only to deliver an antiproliferative drug, and therefore you need to prepare this vessel well. And the success of DCB treatment and its outcome, especially long-term outcome, depends on how well you prepare the vessel. So this is something that we need to remember. But it's always the same. When you do balloon dilatation POBA, there's always this fear of dissection. And it's often stated, this statement, I want to be able to sleep well at night. This is something which is always in the mind of people, and that's why they reach out for a stent immediately or very quickly. So I learned how to respect DCB and to understand dissection, I learned how to respect and understand dissection by the use of DCB. And this is something that we need to relearn actually from the previous time that we use POBA in the treatment of coronary artery disease. This is an example of a person with diffuse coronary artery disease from proximal, left main stem proximal to distal LED, the right, the circ, the diagonal in this case. And I passed the wire to diagonal and balloon and LED, but I lost that wire. And the reason I lost wire was I thought I was pulling out the diagonal wire, and I actually pulled out the LED wire, and I could not get into the distal vessel again. So, but in the end, there was this flow. The dissection was bad, but the flow was TIMI-3, and you don't want to be, you just want to get ahead, not try too much, because once you lose flow, you will not be able to, you lose the vessel and you'll get an infarct. So we brought this back 5 weeks later, and you can see that there is healing and there's flow down, and we were then able to then treat this patient. This is just to emphasize that all dissections are not, you should not fear all dissections. The majority of dissections, especially if we have a good flow at the end, will ensure that it will not cause abrupt closure. It's very, very uncommon for you to get abrupt closure. So this is something that we need to understand and learn. So let me share with you one case of a young man with anteroseptal infarction, and about 2 or 3 days later, we went to do an angiogram for him, and we found that there's a occluded LED. At the same time, there was a large diagonal branch, which was disease, and also diagonal 2. Diagonal 3 in this case was too small. We treated this and we prepared the vessel, and first with the wire went in fairly easily, POBA the vessel, treated with cutting balloon Wolverine, and this was the results after. So the result looks quite good. So when I see cases like this, I say, this is a good case for DCB. This was treated with 2 long DCBs, sequent please neo, and both diagonals were prepared with cutting balloon 2.5 and then another 2.5 DCB for the D2, D1 with a 2.5 and treated with DCB of 3.0 for about 100 seconds. And this is the results after post-DCB. Again, it looks quite good, but this is the moving image. You can find that there is dissection noted in the LED and also diagonal 2, but the flow is good. And this is the important part of it. The flow must be good. And you can see that the DCB post-DCB is about 10 minutes for D1 and about 25 to 35 minutes for the LED. So these are the cases you'll be comfortable to accept. Once again, the final shots. We brought this patient back. He was well. 16 months later to restudy, and there are a number of things you can see that the vessel remains the same. In fact, the area that we treated, there's a slight enlargement as compared to the post-index procedure. And that's the flow post-index procedure and 16 months for after restudy. So the vessel has healed. There's some vessel enlargement. So I believe that looking at the way that things are now, with the use of DCB, the indications are for instant restenosis. I think this is ideal, guidelines supported. But I believe that our use of DCB is going to be mainly hybrid therapy in lesions where it is small lesion, small vessels, long lesions, perhaps side branch. You may want to try to avoid putting in stent, then use DCB. For the more proximal lesions where the data is fairly strong, you may want to use drug-eluting stent at this point in time. But I would think that there is potential use for total DCB treatment, especially when you treat the vessel properly and you get fairly good results, less than 30% residual stenosis, non-flow limiting dissection, and this is where you can use DCB.
Dr. Rosli?
But really, I feel that when the use of DCB
Dr.
is a matter of
Rosli, we have... This
is my last slide, I think. And just to show that the increased number of DCB used over time in Malaysia over the last 5 years. Okay, so I would like to invite you to the AICT Asia PCR meeting in September, and I've put forth Pakistan as National Society to be involved in this meeting. Thank you very much for kind.
Thank you, Dr. Rosli, for the excellent talk.
Recording
Professor
in progress.
Nadeem Hayat Malik, can you have a comment on your experience regarding the drug-eluting balloon?
As Dr. Rosli has shown that especially in Asian patients who have long diffuse disease and you have to put in relatively smaller diameter stents sometimes with not a great looking result. I think in those patients there is a real chance of getting long-term success with using drug-coating balloons, and I hope that the price factor doesn't come into consideration and we can use them more frequently.
Okay.